My name is Brittany Renger, and I'll be covering health and access to healthcare among first-generation Americans in urban areas of the country. First-generation Americans are defined as citizens who were not born in the U.S. and immigrated here. As of 2017, more than 44.5 million immigrants resided in the U.S. That's approximately 1 in 7 people who are foreign-born. In the 1900s, immigrants were largely European. This is a stark contrast to 2017, where Mexicans accounted for approximately 25% of immigrants, and Indians and Chinese were the next two largest groups. Furthermore, the median age of this immigrant population was about 45 years old, 9 years older than native-born people. We're going to focus on these two majority immigrant groups for the duration of the video. Despite socioeconomic status, immigrants in the U.S. initially have better health outcomes than natives. However, while their socioeconomic status improves over time, their health generally deteriorates. Why? One study completed in 2011 examined cardiovascular disease risk profiles of first and second generation Mexican Americans. It revealed that while second generation men and women were less likely to smoke and had lower HDL cholesterol levels, they had higher rates of hypertension. This could be due to societal and psychological factors, such as the pressures of being successful in America, or even simpler factors, such as assimilation to American diet and lifestyle. When looking at Asian American immigrants, the most notable health issue overall is obesity. As of 2014, about 23.3% of the Asian population in the U.S. was obese. Among Asians, second and third generations are more likely to be obese compared to first generation. The obesity rate increases the longer Asian immigrants remain in the U.S. This is also perpetuated by adapting to the stereotypical American diet and lifestyle. We also know that obesity increases the risk of many health problems, including diabetes, heart disease, and certain cancers. We will now look at healthcare access for these immigrant groups. As a whole, public attention is more recently focused on racial and ethnic disparities in access to healthcare, and research indicates that Latinx people have the highest uninsurance rates among ethnic groups in the U.S. This is due to a variety of factors, including education, language, and the statistics in regards to undocumented immigrants. A majority of Hispanic immigrants lack a high level of education, and this impacts the jobs they can secure in this country. As a result, a relatively high percentage live in poverty. Subsequently, many do not invest in healthcare because it is not a major priority. Additionally, many Hispanic immigrants do not speak English, and this greatly limits their ability to become enrolled in government aid programs such as Medicaid. This, paired with undocumented status, contributes to the high amounts of Latinx people without health insurance in America. In regards to Asian American Pacific Islander groups, many community members cannot obtain health insurance due to barriers such as lack of provisions by employers, age, or lack of qualifications for Medicare and other programs. Many elders in particular are affected by the insurance coverage gap seen after retirement. Because of these large subgroups within the population that lack insurance, many do not obtain preventive medicine screenings or other routine checkups. Additionally, going to physicians on a normal basis is not a normative action in their countries of origin. As a result, first-generation Asian Americans often do not get medical attention unless issues are very serious. Similar to the Hispanic community, there's also a language barrier, and many Asian American immigrants feel more comfortable with Asian physicians. In addition to being able to communicate easily, they are said to be more understanding and more culturally sensitive. After discussion about evident health disparities and barriers to access found among immigrants, we will now look at the consequences of these disparities with a focus on the children of these immigrants. We see that immigrants overall have restricted access to healthcare, and this logically leads to more health issues over time because of the lack of use of preventative medicine. However, it is the second generation that begins to move upwards in socioeconomic status, and as a result, more possess healthcare. This is vital because, as we have seen, the overall health of the later generations deteriorates in some respects. Now we'll review some important healthcare legislation that concerns immigrant populations. In 1996, the Personal Responsibility and Work Opportunity Reconciliation Act restricted Medicaid eligibility of immigrants, so those admitted after 1996 could not receive coverage during their first 5 years in the country. This has since been changed. In 2014, the Affordable Care Act began to allow emergency Medicaid for qualified undocumented immigrants. This was a big step for the country and a step towards defining healthcare as a human right and not a business. Overall, there is not necessarily a focus on expanding healthcare for racial and ethnic minorities, but rather those in low-income households. This approach naturally encompasses many racial minorities due to intersectionalities present in the country. While the expansion of Medicaid through the Affordable Care Act has helped a large percentage become insured, there is still much more that can be done. While the U.S. has come a long way in becoming more inclusive, there is still much that should be done in the future. The main issue for first-generation Americans and minorities is no longer access to healthcare, but rather the quality of that healthcare. America is a melting pot of cultures, and for healthcare to be efficient and effective, there has to be a willingness to understand how differences in culture can affect said care. Acknowledging and appreciating our differences is the first step, followed by education and a movement towards institutional changes. The best way to help these immigrants is to listen to their needs first. In conclusion, here are 2 discussion questions you can consider. How can language barriers be overcome effectively in regards to hospital systems and healthcare? And there are currently little long-term statistics on the descendants of immigrants because many racial groups are new to the country. How do you predict later generations will present in regards to health risks?